It's a pleasure for me to be here. I'm Dr. Lekuya, a recent Finn's Bassett Fellow. Today, I have the great honor to introduce Professor Muhammad Tariq Khan. He is the chairman of Alliance Healthcare, Dean of Neurosurgery of the College of Physicians and Surgeons of Pakistan. He's the immediate past chairman of Neurotraumatology Committee of the WFNS, also coordinator of Global Neurosurgery Committee of WFNS. He's the Dean of Northwest School of Medicine in Peshawar, Pakistan. And most important, is a professor and head of Department of Neurosurgery in Northwest General Hospital and Research Center, Peshawar in Pakistan. Also, we can add is a convener of Neurotrauma Committee in Pakistan, and also the past president of Pakistan Society of Neurosurgeons. So this means there's a lot to give for his introduction because of time, and then to make it short and structured. So I will stop by that point. Also, I'll invite him to start his presentation, and you are welcome to watch it. Professor Tariq, you're welcome.
Yeah, hi, Harvey. Thank you very much. I'll try and share my screen here. Okay, can you see my screen? Yeah.
Yes, we can.
Looks good.
Okay. Yeah. Okay. First of all, thank you very much for inviting me. I'm very grateful to Professor Robert Dempsey, to Jeannie, and the rest of the team. Finn's, as you all know, has been doing a great work in education, in healthcare, especially neurosurgery throughout the world, especially in lower and middle income countries. And I'm very grateful to them for doing all this, and especially these educational webinars now as well. So, so my talk is on neurotrauma care in low resource settings. As we all know that there is a big burden of TBI, especially in lower and middle income countries, and that 74% of surgeries for TBI in the world are needed in LMICs. These are surgeries which are required, not actually done. So these are figures from Key Park and WFNS. And then 89% of surgeries for traumatic spine injuries also occur in lower and middle income countries. 5 million neurosurgical cases go untreated each year. This is in part due to lack of neurosurgical care providers. The World Federation of Neurosurgical Societies has spearheaded efforts to monitor the number of neurosurgical providers around the globe since 2016. In this perspective, we discuss why, when, and how the neurosurgical workforce should be measured. Hold on. Just a second, I can't seem to forward this here.
It was just next to it, down there.
Yeah. No, hold on. There's a problem there. Give me a second. How do I get this down? Here.
This thing.
Oh, let's see. This thing needs to go down.
You want to share this?
Yeah, this arrow. There's another arrow here. I'll just do it. Go back. Okay. So this was the Global Neurosurgery Workforce Map, which was made by the WFNS, and it showed that what is required in the lower and middle income countries, really. And when I came back to Pakistan in 1990 from my training in Ireland, mostly in Belfast, and I found that There were very few neurosurgeons in the country, and this was what was the type of traffic and things like that, and we wanted to know how to handle this large influx. And we looked at how to innovate and then try and inform people through research and integrate ourselves into the health system of universal health coverage. And I think the important thing is to take a holistic approach, right from prevention to rehabilitation, and of course have the pre-hospital care and the ward care and ICU care, which are very important in that. We did a survey in 2016-17, the Asian Australasian Society of Neurosurgeons Neurotrauma Survey, and we had the hospitals from Peshawar, a few from India and in Indonesia. And we looked at the helmet and seatbelt use in the survey, and as you can see that hardly anybody at that time used any helmets or seatbelts really. And of course, we tried to get into the Guinness Book of Records to try and get as many people on motorbikes as possible, and we think that maybe one helmet would protect everybody. So I felt here in Pakistan that we need to try and look at that prevention is better than care. And we tried to do something about that to try and educate the public. And we did many seminars and poster competitions, and they became so popular that one of the colleges put them in their BS program to teach young students regarding prevention of neurotrauma. And then recently we joined Think First, and also the Neurotrauma Committee of the WFNS joined hand with Think First International. And we had our first public awareness seminar in Peshawar in 2019 with the ICRAN. And I say this because it's very important that just a few weeks back, when there was a cricket match between India and Pakistan, and when Pakistan won that match, there was firing in the air, and 12 people died only in Peshawar from stray bullets and spent bullets. So I think prevention is a very big thing which has to be looked at in all the countries, especially in lower and middle income countries. Then this survey looked at who provided emergency treatment at the scene of injury, and it was found that majority were looked after by the bystanders, by lay people, and there was no person available at the site for that. Then whether did a nurse or doctor accompany the patient? And no, majority were brought in their private vehicles, and even if they came in an ambulance, there was no nurse, technician, or actually no oxygen or suction even in that ambulance. And we know that 50% of people who die from TBI do so within the 2 hours of surgery, and 40% of pre-hospital deaths are potentially preventable. In the pre-hospital setting, availability of transportation and lack of organized emergency medical services are the most significant impediments to providing optimal care. And we know that in a study comparing pre-hospital deaths, 59% of trauma deaths occurred in the field in the high-income settings compared to 72% in middle income and 81% in low-income countries. And in one large-size study of Kenya, only 52% of patients arrived at the hospital within 30 minutes after a road traffic accident, and only 72% within 1 hour. And of course, that made the duration to surgery also very prolonged, and a lot has to do with the long distances also being covered, and especially in Peshawar, when a lot of people are coming from across the border from Afghanistan. And we know that treatment is geared towards prevention of secondary injuries and rehabilitation. And secondary injuries like hypoxia, hypotension, edema, raised ICP to increase mortality. So the longer the delay, greater the mortality. Because of this, we worked a lot in Pakistan, and I'm sure in other lower and middle income countries, on developing good ambulance services. And we have succeeded here in developing what they call 1122, and they're being trained very well and equipped now to be at the scene of accident within 20 minutes, which is a very big achievement for us. And now this is now being going to the peripheral areas as well. And then, of course, developing guidelines, first of all, to agree on the minimal standards of care a core guideline and a system of care which grows as trained personnel and resources become available. What important is that the assessment of need, that the epidemiology of trauma and the guidelines look at the local resources. What profile the local data and the geography will transpose difficulties and the resources available, and then develop those protocols. And this was a very good article written by, or worked on by Professor Andres Rubiano from Colombia and his team. And they came up with the recommendations of the Colombian Consensus Committee for Management of Traumatic Brain Injury in Pre-Hospital, Emergency Department, Surgery, and ICU, beyond one option, what they called stratified protocol, bootstrap. And this was the first time something on which we wrote a commentary was that from standard-driven protocols to resource-driven guidelines for neurotrauma management in low and middle income countries. And these guidelines address treatment interventions, monitoring, and treatment thresholds that are specific to TBI or that address a risk that is greater in patients with TBI. It's not intended to cover all topics relevant to the care of patients with severe TBI. Topics related to general good care for all patients or all trauma patients not included. These recommendations are intended to provide the foundation on which protocols can be developed that are appropriate to different treatment environments. And the areas covered are pre-hospital care, emergency room care, surgical theater care, ICU care. And these protocols are now being tested also in Colombia and other areas, and hopefully they can take a shape. And this was an initiative taken by the Neurotrauma Committee, and Professor Andres Rubiano really did a very good job for that. I would recommend that all the young neurosurgeons must look at this paper really. We know that the in-hospital management is guided by GCS monitoring, CT scan, ICP monitoring, pupillary response, and the goal is supportive treatment and prevention of secondary damage. The Brain Trauma Foundation guidelines, which are evidence-based, have general maneuvers with head elevation, normothermia, sedation, volume resuscitation, and the first-line therapy is CSF drainage, hypocapnia, mannitol administration, 3% saline also is being used regularly now, especially in pediatric patients. And the second tier is high-dose barbiturates, intense hyperventilation, increase in mean arterial pressure, mild to moderate hypothermia, and then, of course, decompressive craniectomy. And of course, there's level 2A evidence that bifrontal decompressive craniectomy has been shown to reduce ICP and stay, but not the Glasgow outcome score, extended outcome score at 6 months. And the important thing is, whenever doing a decompressive craniectomy, that it should be a large frontotemporal parietal, at least 12 by 15 centimeter, to reduce mortality and improve neurologic outcome. And there was a very good work done on a consensus meeting in September 2017 on the role of decompressive craniectomy in the management of traumatic brain injury in Cambridge. And I think I would recommend to all young listeners to read this consensus statement from the International Consensus Meeting on the role of decompressive craniectomy in the management of traumatic brain injuries. And also, as a follow-up to that, in the meeting in Naples, ICRAN, there was a consensus made on putting the bone flap back in on that. So also there will be evidence that data from ICP monitoring reduces hospital stay and 2-week post-injury mortality, and should be monitored in all salvage patients with GCS 3 to 8 after resuscitation with CT changes. ICP monitoring is indicated in severe TBI with normal CT, but having 2 or more features on admission, age greater than 40, unilateral bilateral motor posturing, or systolic blood pressure less than 90. We all know, we have seen the high-end ICU beds in the high-income countries, but we also know what is available in the critical care in the lower and middle income countries. There's hardly ports for oxygen and suction in that. So it is very, very different. Now, majority for the guidance for lower and middle income countries, we know first of all that majority of the patients are managed without ICP monitoring. There is no recent literature to guide management in non-monitored patients, and large part of literature comes from well-equipped large centers in high-income countries. And there's no resource-based guidelines and LMICs to guide surgical TBI management. So I just take you to this Best Trip Trial 2012, It was the only tested non-ICP monitored treatment protocol. I know many people had issues with it, but this trial found no evidence of outcome difference for monitored and non-monitored patients. And then this trial compared ICP monitored patients versus non-monitored with imaging and clinical examination called the ICE protocol. And this was this paper which was written and published, consensus-based management for the treatment of severe traumatic brain injuries. So consensus revised ICE protocol, the CREVICE protocol, is not a substitute, but a supplement for empirical evidence. It's an effort to provide for the vacuum left by the absence of evidence-based guidelines, and it was developed using the Delphi technique. So how do we do it in our center? So first of all, if there are patients who come in whom we feel that they need surgery, so they straight away go in for a decompressive cranectomy on admission. The second is if we are going to monitor them, and if possible, we would put in an intraventricular catheter and then monitor the ICP, and depending on if the ICP is high, above 20 for some time, we would do a decompressive craniotomy. And then we use the CREVICE protocol. Now, the indications for decompressive cranectomy for us are the CT scan findings with diffuse brain edema with or without brain contusions and subdural hematoma, the effacement of basal cisterns and ventricles, midline shift, GCS 9 to 12 or a drop, and refractory ICP. And the management protocol using the CREVICE is dependent on the Marshall score on CT scan, the interval CT scans, the Glasgow Coma score, neuro worsening, the pupillary response, and then we have a 4-tiered management response, although we never went to the 4th tier, but it's the 4-tier response. You all know about the Marshall grading. It depends on the cisterns, on the midline shift, and on the mass lesions. And for that, the major criteria are compressed cisterns, midline shift, non-evacuated mass lesion. And minor criteria are GCS, pupillary asymmetry, abnormal pupillary reactivity, and CT classification of Marshall diffuse injury. And the neuro worsening is decrease in motor GCS of 1 or more, new loss of pupillary reactivity, interval development of pupil asymmetry of greater than 2 millimeter or bilateral mydriasis, new focal motor deficit, herniation syndrome, like the Kushner triad. And the imaging is on the time of admission, then repeat at greater than 12 hours if initial was done at less than 4 hours, then 24 hours, then 48 hours, and then PRN. I know in many centers in lower income countries, even one CT scan is difficult. And I know a lot of people would do decompressive cranectomies as a what I may call a prophylactic decompressive cranectomy because they're not able to do CT scans, etc. on these patients. And the tier 1 treatment for CREVICE protocol is scheduled hypertonic saline, 4-hourly, for example, scheduled mannitol, and maintain normothermia. And tier 2 is hypoventilation, hypertonic saline, if available, and then increase in sedation. And then tier 3, we would go for decompressive cranectomy because giving high-dose IU barbiturates or hypothermia are difficult, and again, that is controversial as well. And then this is the 4th one, untested protocol with nimodipine and magnesium. And the escalation is done looking at the neuroworsening, decrease in the GCS, pupillary asymmetry, new focal motor deficit, herniation syndrome, no improvement or worsening on follow-up CT scan, no acceptable response to initial therapy. And basically what happens is that every 24 hours, the CT scan is done, the sedation is stopped, patient GCS is noted, and then managed accordingly. And this is the matrix for that is done. Now, important matrix is regarding when to wean off the patients from the ventilator, especially when we are not monitoring their ICPs. And you can see that the red one is that it should not be weaned off. The yellow one means that you use caution, and the red one, green one is safe to wean. And as the day goes by, and after 72 hours, you can see more patients you can wean off. So I think this is the matrix which gives you an idea how to take or wean off the patients from the ventilators. And then most important thing, which we have a big problem, is rehabilitation. Who are they discharged to? In lower and middle income countries, they all are discharged to the family. And we found that it was one of the most important part, which is often neglected in developing countries due to poor resources, even in high income countries, I would say. And I know that is the role of a multidisciplinary. So what we started doing was, there was a very interesting paper from Aga Khan University in Karachi, and they talked about the role of family members in training. And we started training the family members on how to look after the catheter and bed sores, et cetera, et cetera. I think so that's something which should be tried also. I just want to touch on the Peshawar recommendations. These are comprehensive policy recommendations for head and spine injury care in LMIC, developed by Harvard Group of Key Park and ourselves. And basically, these were policy recommendations for policymakers. And the idea was to have a unifying vision for global neurosurgery, and that 80% of the world has access to essential neurosurgical care by 2030, and 80% of the world is within 4 hours of a neurosurgical center by 2030. And we hope that 90% of LMICs with national neurotrauma plan is in place, which unfortunately because of COVID was delayed. But the idea was to have a timeline and get something. And I think we have done a fair bit now, and there was a very good response in the WFNS Bogota in 2022. And this whole thing concept was to try and connect to the universal health coverage 2030 of the WHO. And in Pakistan, we were able to develop the national vision for surgical care. And we had the provincial engagement workshop back in 2019. And we were able to piggyback hydrocephalus and brain trauma onto the National Surgical Vision 2025. And then global neurosurgery, the idea was that in addition to doing neurosurgery better, how to better deliver neurosurgical care to all who need it. And then the WFNS created this new committee, the Global Neurosurgery Committee by Franco Savade. He did that, and the Key Park and Abu Samad were the first chair of that committee, and it was launched also in Peshawar in the ICRAN in 2019. And again, the idea is to align and coordinate all global neurosurgery activity within WFNS to reach the goal, to stimulate and facilitate relevant research to inform policy, to engage with surgical stakeholders for building integrated surgical systems, to co-educate for investing in surgical care for all within universal health coverage. And interestingly, we have done a lot of work in Afghanistan. We've got the neurosurgeons in Afghanistan together. We were able to send them a lot of equipment helped by us in Pakistan and by the WFNS Foundation. Very recently, I think it was last year, September, a year ago, we sent 20 surgical laminectomy and craniotomy sets to 10 centers in with the help of the WFNS Foundation and ourselves. I think it was a great help to them. And also now the Global Neurosurgery Committee, as you know, all are working with Sierra Leone to develop neurological surgical services there. There was a lot of talk about task shifting, task sharing. As you know that in Australia, they still have been doing, helping the general surgeon do these surgeries. And now with the training and feedback, the teleradiology, Skype, virtual surgical systems and guidelines, I think may be possible in remote areas to guide general surgeons to do neurosurgery if at all is required there. And here I would like to invite all of you to the first WFNS International Global Neurosurgery Conference on the 10th to 12th March 2023 in Peshawar, Pakistan. We can try and help the residents with accommodation, hopefully, if anybody from abroad is coming to this conference. Thank you very much.
Thank you, really, Professor Tariq, for this interesting and detailed presentation. You took us from the beginning, where we used to miss the actions, and also at the end of the care, the rehabilitation, where most of the low middle income country also miss the actions. So we are mostly in between when the patient arrives at the hospital and when we send them home or to the rehabilitation. So thank you for taking it from the beginning. A good reminder, and then we really interesting to see how people react about it. So I don't know. I will first invite Professor Dempsey. Is you have something to comment, or the panel member?
Well,
You're
I
welcome.
I think that the panel will wait for the young neurosurgeons to ask questions, and you might start with your first question yourself.
Okay. That's really interesting. So the first question is always when we can't implement the ICP monitoring protocol, and it's a challenging system. Some countries have tried and then to implement as a routine protocol, but they have challenges of sustaining that protocol because of infection risk, and also there's a lot of mistakes. I don't know what your advice, because we kind of not doing for good practice when we don't implement it, but those who try, they also do a lot of harm. So I just want to see your feedback. Thank you.
Yes, thank you very much. Definitely, first of all, it's very expensive and depends on what type of things you're using. So what we ended up was that we felt that we use the intraventricular catheter, and by tunneling it, I think the risk of infection is much reduced. But I think after 72 hours, the longer it stays in, of course, it's going to be more infection there. But I think the main problem is the expenses. I think you know that people have to pay for the CT scan as well. So like paying for the ICP screws and for the fiber optic ICP monitoring, it's very difficult. So what we found that either we were just leaving them just like that on a bed and giving them mannitol, and then we would ventilate them. So this has been happening over the years from 1990. When we started off, I would just do a tracheostomy for the patient to help in their airway management, and that was all we could do. And now we ventilate everybody. But then when you ventilate somebody without ICP monitoring, the only thing which we have left is looking at the pupillary size and maybe the blood pressure as well. So I found this ICE protocol of Randy Chestnut an idea to test, and we're doing it as a testing for the last couple of years to see how it works. So I think one has to have some way of measuring, because you can't just sedate and paralyze the patient and not know what is happening there. Thank you.
That's really challenging.
Tariq, could I follow up on that? Just a question. I think the most tangible information we should give is so many of these groups can get the initial scan, but the repeat scans are quite prohibitive in cost. And could you give them just some very practical clues about the clinical exam plus ICP that would allow you to dictate treatment, or also when you would demand a second scan based on those practical, simple things that they should be looking at on every patient?
Yeah, so obviously, if you take aside the ICP monitoring, which is not available to majority of the places, I think if you're not ventilating the patient even, which majority of the people cannot do even that, but I think the pupillary response is very important. Hemiparesis developing, new hemiparesis developing, or raise in the blood pressure, or the GCS going down, should, even if you cannot do another CT scan, should guide you towards either doing a decompressive craniectomy, or if possible, to do a CT scan. If you ventilate the patient, then of course, as I said, it's better to, again, the only thing that's left is the pupillary response and the blood pressure. But if you wake the patient up every 24 hours, you can get a better idea whether they have developed any neurological worsening. So I think it's the clinical examination is the thing. And I must tell you, when I came to Peshawar in the first 6 months, we had no CT scan. So I had to go on the clinical examination and do the usual multiple burr holes, frontal, parietal, occipital, many a times under local anesthesia to see whether we can find a hematoma or not. Thank you.
I think that the clinical exam should never be underestimated, but the important thing is, even in a low resource setting, we can monitor ICP. We can monitor it with subdural bolt, we monitor ideally with ventriculostomy, and we can, even without electronics, we can measure the height of the water pressure and combine that with the clinical exam to say this person needs a decompression. And I think those simple steps are the most likely to save life. But as you pointed out, importantly, we next need to look at saving function, not just life, but function as well, which is important. Back to the
And sorry to add here, as we all know that the decompressive craniotomies can save life, but we can end up with too many vegetative patients. And then again, it's a very big burden on the society. So we must be very careful also looking at that as well. And I think Stephen Honeybull once said very nicely that you should look at yourself, what would you expect people do to you if you were in that condition? I think that also answers a lot of things.
Do you have other questions?
Should I top up my second question, or I first check if someone else has a question? Is there anyone in the room who has a question? You can type, or you can just put on your microphone, then you can ask the question. Or raise the hand so that we can anticipate.
Thank you for the presentation. Mine is not a question. Okay, thank you very much. Mine is not a question, but just to comment on our own experience in Nigeria. The facilities are available, but it's quite expensive, and many patients cannot afford to pay out of pocket for this monitoring. Is there any advice you can give us on how to offer such service for such patients when there is limitation of resources? Thank you.
Yes, thank you. As we discussed earlier on, I think the clinical examination is the key. Really, I think that's the most important aspect which needs to be done, and which should not be forgotten, even if you are monitoring the ICP. And I know it is in lower income countries, it is very difficult because of resources, because of the availability of the monitors. But as Professor Dempsey pointed out, we use the intraventricular catheter, and we use the hydraulic to check the ICP, or we connected through a hydraulic system to the monitor and are able to do that. So I think it can. So it does two things. If you have a hydraulic system, that if there is raised ICP, some CSF will be coming out that would automatically try and reduce the ICP also, and you would also get an idea of measuring the intracranial pressure. And I must remind you, and I must tell you that we back in the days even used pediatric nasogastric tubes. I know people are very against that, but we had very good results with that to drain CSF as well when we had no other resources. Thank you.
We have a question in the chat. Dr. Kasirye is asking a technical question to know if doing a hinged craniotomy is maybe a substitute of decompressive craniotomy. That's his question.
Yeah, definitely. I'm sorry I missed that out. Definitely, it saves a second operation. And there has been a preliminary study on it already, and I think now there's a plan to have a major study to look at the hinge craniotomies. Many of us have done them without realizing what we were doing. We were just loosely placing the bone flap. with a couple of sutures so that the bone flap could raise if there is pressure. But there's a specific place for it. I think you cannot do it in every patient. You know, with a decompressive craniotomy, if the swelling is a lot, you don't want to place the bone flap. But there are patients in whom maybe the brain is not bulging that much, and you can just loosely place the flap. And now it is being called hinge craniotomy. It was done before also, but there was no name for that. Thank you. Yes, definitely.
Yeah.
Okay.
My experience there is that may be more useful for other pathologies like a focal tumor swelling.
Okay.
Because as the professor pointed out, for the major traumas, the large decompression is the way you're going to control the ICP, and not a small focal hinged one, but rather large.
And then he has a second question to know, what about indication for bifrontal craniotomy? I think that's referred to DECRA protocol previously.
Yeah. So definitely, if there's diffuse brain swelling and raised ICP, or if you feel that the patient is going down, doing a bifrontal craniotomy, and you can open the dura and you can cut the forks to make it into one compartment. It would be very, very helpful in that. But I think people are using mostly unilateral. Definitely bifrontal craniotomy has a role there in diffuse brain swelling. But some people would cut the forks to make it into one compartment, some people do not. So there is a different viewpoint. But I think if you do a bifrontal decompressive craniotomy, it's better to cut the forks anteriorly so that you make one compartment. Thank you.
There's another question which was sent to me privately. I just put it publicly. It's addressed to you, Professor Tariq. The question is a comment on the risk of ICP monitoring or EVD in low income countries. Yeah. Just the question. Can you see the question?
Just let me.
The last one, I think I put just before one. So you want to know the.
Yeah. Okay. Definitely. Okay. That's Professor Hameshi. Yeah. Shabani. Yeah. Definitely. But if wherever possible, I am very convinced. If wherever possible, ICP monitoring should be done. I think it gives you a very good tool. An excellent tool to be able to, but if you cannot do it, you don't have the resources, then as I said, and as Professor Dempsey also said, that clinical examination is of utmost importance, and whether you are monitoring ICP or not. So the first basic thing is clinical monitoring. Thank you.
Yeah, I really want to highlight this question because I believe our role is to bring modern care in low resource areas. And there are innovative ways I've been shown. And I must say, this is the way I was trained, was that we could take a three-way stopcock, which cost dollars, pennies, trim the bottom, make a small hole the size of the three-way stopcock, drill that into the skull, open the dura, and we had created a $3 ICP bolt, which we could then measure against a fluid pressure column. The technology was literally 12th century, and it worked well. I once monitored a child for 5 weeks that way and was able to adjust the ICP. This was an encephalopathy patient who survived normally once we were able to clear that encephalopathy. But you can monitor ICP if you need to, and you can do it inexpensively. It is essential, as the commenter pointed out, that it be clean, that it be the dressings be cared for, because infection would be a disaster. But a bolt infection is far less devastating than a ventricular infection, which is far less devastating than a a brain abscess. So I think for many reasons, we can learn from our colleagues about straightforward, simple ways to achieve the same clinical measurements that we would use at Harvard.
Oh, that's very interesting thing which you have pointed out. I think we need to look at that.
Yeah,
Definitely.
if you
Yeah.
look at the very expensive metal bolts to monitor pressure, they're nothing more than what I was using in 1970, which was a stopcock, and just modified it, drilled the hole in the skull to the stopcock, and the patient was monitored.
Yeah, excellent. Yeah, definitely.
Yeah, I think the question was also like addressed partially. One of Dr. Jogi Patisapu, I don't know if it's fully, he wanted to know about the long tunneling, if it's a question. I actually want to top up another question on his question. Sometimes when brain swelling is too much, the ventricles are slit, and then we don't put it under navigations, and then what's your advice? There's a slit of ventricles, then also the anatomy is almost distorted. So you're kind of going to new anatomical landmark, and it's also dynamic. Maybe your scan is like 2 hours, then what you're doing is another thing. Yeah, just a comment on it, please. Thank you.
Yeah, hi, Jogi. Yeah, excellent. I think a long tunnel is very important if you're putting in a ventricular catheter. And as Professor Dempsey pointed out, as I said, you can use a hydraulic system and check the levels rather than connecting them to a monitor. As far as infection is concerned, I think if you have a long tunnel, there's less chance of infection. But I think over 72 hours, it can get difficult. But I would love to try what Professor Dempsey said to use that, develop a sort of a bolt, because as Professor Dempsey pointed out, putting in a ventricular catheter, having a ventricular infection is much more dangerous and can cause a lot of problems than putting a bolt like that. Agreed. I think even in high-income countries, when you're putting in a fiber optic thing or whatever, infections are there, it can happen. The question is just to keep everything as clean as possible, really, as less interference with it, and whenever using gloves and all that. Thank you.
Could I ask a question?
Yes, please.
Yeah.
Dr. Russell, welcome.
I think Professor Dempsey's suggestion is great, and that might be a good technical note to be published in one of the, neurotrauma or something like World Neurosurgery. Also had a comment about imaging. Maybe there's been a survey of what centers have CT available and the cost to the patient. Another aspect I think is pretty common in LMICs is how often is the electricity out, the power out, and you can't get a scan. And that would play into the CTs now that are becoming available, the mobile ones that are battery powered. And how much of a need is there for something like that in LMICs? So I don't know if a survey along those lines has been performed, or that might be something to do.
Yeah, hi Russ. Yeah, definitely there. The survey which the Global Neurosurgery Committee and of course the WFN has done, they have looked at which centers have CT scans or not. But of course, I think this survey has not been done. What about the electricity availability?
And the cost to the patient too.
And the cost to the patient is. I think the costing has been done, but this other issue, when you have serious patient, there's no electricity. So these new CT scans, and especially the one which we had a meeting on, I think with the battery operation, I think they would be very good for low middle income countries, definitely.
Mm-hmm.
Okay, again, coming back to the question of Dr. Shabani about kind of lobbying to convince some company to bring ICP monitoring device in the low middle income countries, just like it has been with the shunt, the Shabra shunt that we use now. It has solved too much about endocephalus, although there's a lot of dynamic on that point. But I think it's also one of the questions we can look at to solve that problem. Find a design which is a bit cheaper and then with low risk of infection that can be applied just as Dr. Dempsey has
Please,
suggested.
I'm on Zoom.
Yeah, it may be a way to go, kind of advocacy for way forward. I don't know, that's to the panel to think about.
Yeah.
I think that your question really allows us to say that while every location is different and the way they finance CT scans or the way they supply appears different, they also are very the same. Everyone needs a certain level of trauma care. Every country does. And we in neurosurgery can spearhead it. Everyone needs to decide what is survivable with quality of life. And we all know in neurosurgery that especially in young people, really miraculous recoveries are possible. But we have to be sensible about things that cannot. And then we have to begin to triage resources. But nothing is more compelling than a child or a young adult with a survivable head trauma. And then all these things that Tariq told us become essential. And we can mitigate the injury by looking at principles of vascular homeostasis, ICP management, survey for swelling or hemorrhage, and appropriate time treatment. And our job is to advocate for that they'll have access to ORs, access to CT scanners. The world has changed so much for the better during our careers. We need to build on that momentum by advocating for the people of the future. And I don't want anyone to feel low income setting, we can't do that. We're pretty smart. We can figure out a way to monitor that pressure. We can figure out a way to provide basic, which is the most of neurosurgery is our basic care. And then we have to collaborate for the things that are more advanced. Well done, very well done.
Good advice for emphasize where we have the strength, we use our strength to optimize the care rather than looking for opportunities, I think.
And the innovativeness that I see in low and middle income countries is phenomenal. I mean, I always learn more than I teach, there's no question.
Yeah.
We have about 7 minutes remaining for the meeting. Any other burning question?
Not good. Tariq, do you have any last comments for the audience? Sort of the summaries about where we are with trauma care in the low and middle income countries and where we will be soon?
Yes, definitely. I think really when I look at myself, when I landed in Pakistan in 1990, what was there, the number of neurosurgeons and the equipments and the infrastructures and everything, and what I see now, there has been a vast improvement in that, both in the numbers of neurosurgeons and in the facilities and the provisions of CT scans all over the country. I think really we are moving forward, and it's obviously the same all over the lower and middle income countries, because the neurosurgeons are very dedicated to improve care. And as I said, the most important thing all over the world is the prevention is the most important thing, to try and as much as possible educate. If you look at the helmet laws in Vietnam, in one day they suddenly dropped in Hanoi the mortality and morbidity tremendously. So this plus the dedication and the hard work of the neurosurgeons and their teams with them, the nurses and the technicians, everybody, I think we're going towards much better care, hopefully in the near future. And an important thing is the collaboration amongst all the groups, and wonderful work people are doing to try and to help all the New Circle communities. Thank you.
Thank you so much. And Dr. Likui, you have done such a marvelous job as a moderator. Do you have any statements for us? Or what have you learned today?
I think also Moody has his hand up as well.
Oh, I'm sorry.
Dr. Qureshi want to ask one question, then I will maybe add.
That would be wonderful. Moody, please.
Thank you very much. It's more a comment. Tariq, you have done what a lot of studies from across the high-income countries never managed to do. What you've brought into the paradigm is the reality of traumatic brain injury, because you've focused on LMICs and you've very, very eloquently displayed and shown that what is being developed from protocols in high-income countries may not necessarily be applicable. And I think that's a point that Hamisi was trying to bring in. That said, wearing the continental hat for the societies of Africa, and having, as Paul and I have done, along with Bob, traveled across the sub-Saharan countries, gone and seen many, many different areas. There's a whole array of, or a variety of management settings. We have, for example, in the Red Cross in South Africa, in the UCT, LICOX monitoring and the chemical analysis monitors, which are really the high end of management, and they've shown their benefit in reducing mortality in that setting, to the many multitude of centers where head trauma is managed not at all by general surgeons, but by not at all by neurosurgeons, but by general surgeons. And you find them lying on the bed or sometimes on the floor, being managed as best as they can. So there's a whole range of them. But I think your lecture serves to bring to everyone's attention that we really need to move on within our resource capacity to a more modern way of, or a more appropriate way of managing them. And I just wanted to suggest perhaps that there is the Cannes Congress coming in from the 9th to the 11th of November, and a talk like this, when almost every society from the continent will be attending, it may be appropriate for such a talk on a plenary session to kind of boost this idea of better management of traumatic brain injuries. And I'd love you to perhaps consider registering and coming over. That said, there was a question about the ICP monitoring. And when I first came back in 1992, I ended up utilizing following trauma, just a straightforward, simple subdural tube using a feeding tube connected through a three-way tap to a water level, and we're just using normal saline plastic bottles adjusted onto a drip stand. And for the first 4 or 5 days, studies have shown that that subdural monitoring is actually quite in tandem with intraventricular monitoring, which is a challenge in our setting, particularly when you don't know what the ventricles are looking like. And then it's after about 4 or 5 days that the discrepancy between intraventricular monitoring and intraparenchymal monitoring becomes sort of wider, and then it's not as useful. But for the first 96 hours or so, that subdural monitor works very well. And it's nothing more than a size 6 or size 8 feeding tube, a baby feeding tube connected to a three-way tap and an IV giving set onto a tube which is a fluid level. And I think someone I think Jogi mentioned that. How about options for water levels? And I think having used them, it is something that can be used. And of course, there's always the problem of risk, but after 4 days, 5 days, you pretty much have gone over the worst and you can pretty much remove that. So yes, we work in environments where there's a whole range of management strategies for TBI, but I think a lecture like this, and Harvey, it's really nice that you, are you working in Mulago now, or are you back in DRC?
Back Mulago still.
Okay, great. So nice. And I really think that such a lecture is going to, or at least entice or encourage folks like Hamisi and Juma and Shafiq Kassiria to think about how they can utilize this in their settings. And I'm sure they've learned a huge amount, but I do wish to suggest that as many from this panel try and make it to the Cannes Congress, because it's a showpiece for what's available on our continent, Tariq, and it's not very, very different from the settings that you work in Pakistan. So thank you very much for a brilliant talk. And again, as Dr. Dempsey said, Harvey, very proud to see that you're conducting a very international level webinar as a Bassett Fellow of PIANS, and doing us proud. I'm very, very happy to see that. And Edie,
WFNS Fellow.
and a WFNS Fellow, of course. You're getting the scholarship from the WFNS as well, and really making us proud. And you're going to give the exams of the COSEXA, which Paul, Bob have all been instrumental in developing in our region. So we're all kind of a family sitting here and looking at the fruits of that hard labor that's been taken almost 2 decades. So a very, very gratifying moment indeed. Thank you. Thank you for brilliant talk and brilliant opportunity to share thoughts. And we look forward to Hamisi and Juma and Edie and everyone coming to Nairobi as well. So thanks again. And Russ, always nice to see you.
Wonderful.
Okay. I don't know if I have to add more, since Dr. Qureshi has already wrapped up everything. My take-home message today is from the presentation. I like the emphasis on the pre-hospital care that we used to live away. When we talk about TBI, we see patient already in the hospital. That's our job. We need to really plan from the injury site, but also after surgery and discharge, we think the work is done, and then it's a lot after coming, rehabilitation and follow-up long-term. So those are some of the key things I've learned also from the wisdom of the panelists, that we can do more with our clinical skills and innovative approach than just looking for fancy device to provide care. That's maybe my take-home message. And I will give back again the floor to Dr. Dempsey to wrap up and close the meeting. Thank you.
Thank you so very much. You did a wonderful job. We're very proud of you. I want to particularly thank Maggie and Jeannie, who've been so instrumental in organization of this and our future meetings as this goes on and builds. So I really tremendous thanks to them, and thank everybody for participating, especially Tariq, our good friend. It's wonderful what you've done for us today. So I wish you all the very best. I hope the weekend is good to you and your families. Do take care. We hope to be seeing you all very soon. Take care now. Thank you.
Thank you. Thank you, everybody. Thank you, Bob.